Myra Butler, a recent graduate from medicine and currently completing my Master's of Health Science in Clinical Epidemiology at UBC. The objectives of this module are to introduce the 5 explanations for a statistically significant association, define and distinguish the concepts of bias and confounding, and to understand a little about the broad categories of selection and information biases. Before jumping into the confusing topics of bias and confounding, let's answer the question, why should I care? The easy answer is that they are everywhere, making it difficult to strain out the truth from studies. I find it helpful when assessing studies to remember that there are usually at least 5 explanations for any given statistically significant association. First, there may not be a true association at all. What we measured may merely have been the result of chance and sampling. In general, we use statistics to help put limits on the amount of chance associations, but it remains a possibility. For example, if you toss a coin 10 times, you don't expect to get 10 heads, but it is possible due to chance alone, despite being unlikely. Next, you must consider both bias and confounding as explanations before moving on. More on these to come. Reverse causation is exactly what it sounds like. For example, it might be noted that people with knee pain are obese. It could be concluded that obesity causes knee pain. However, it may also be that knee pain causes people to stop being active and therefore become obese. The direction of the causality might go either way. I like to think of each of these 4 first explanations as hurdles the association must pass in order to reach the goal of possible causation. In this module, we will leave aside the other explanations and focus on the concepts of bias and confounding. Bias is any systematic error in an epidemiological study that results in an incorrect estimate of the association between an exposure and an outcome. Key ideas here are that it is a systematic error and an incorrect estimate. Please note that bias in the epidemiology sense does not necessarily involve a preconceived or prejudiced notion of what ought to be so in a study, as you might use the word bias in other contexts. Confounding, on the other hand, is a situation in which the effect or association between an exposure and outcome is distorted by the presence of another variable. Let's explore this idea with some examples. It has been shown that as the sales of ice cream increase, so does the rate of theft. So, does this mean that ice cream causes crime? Let's think about this carefully. Looking at the data available, it might make sense to conclude that ice cream causes crime. However, when you dig deeper, you find there is a 3rd variable that explains both the increase in ice cream and crime. It just so happens that people buy more ice cream and steal more on sunny days. There's actually no direct relationship between ice cream and crime at all. Let's try another one. For years, it was thought that caffeine caused cancer. This is a much more plausible scenario, but don't worry, you don't have to give up coffee. It turns out this was another case of confounding. The caffeine, or coffee, had very little to do with the cancer rate. What was actually to blame for the higher cancer rate in those who drank coffee was the fact that a good portion of those drinking coffee would have a smoke at the same time. It was the smoking that caused cancer, not the coffee. When considering possible confounders, I find it helpful to construct a confounding diagram. Begin with your exposure and outcome of interest. Your confounder must be associated with your exposure. For this association, there does not need to be any causation, or causation may go in either direction. The confounder, however, must have a clear effect on the outcome, hence the single direction arrow. This is the picture I imagine when I'm trying to remember the definition of confounding. Just about anything can be a confounder. Some common ones to look out for are age, gender, ethnicity, indication for treatment, smoking status, and placebo effect. It's important to remember that each set of exposures and outcome will have their own set of possible confounders. If you're planning a study, it's very important to search the literature for similar studies to find possible or even proven confounders before starting. That way, you can plan in ways of dealing with those factors. Much of the field of epidemiology is devoted to figuring out how to detect, measure, and get rid of confounding, but that doesn't help you if you don't consider it. The most effective method of decreasing confounding is to use randomization. This method controls for both known and unknown confounders, making it a very powerful tool. Having a control or comparison group will also help to remove some possible confounders, such as the placebo effect. Unfortunately, you don't always have the time for a randomized controlled trial, and in some instances it would be unethical. Another possible way to deal with confounders in your study is to stratify participants into levels of a confounder for comparison. Alternately, if you know, for example, that age is a strong confounder for your study, you may choose to study only a very tiny age range, a strategy known as restriction. When all else fails, you can use statistical methods to adjust for confounders. There is absolutely no substitute for good study design. A statistician may be able to magically transform seemingly useless data into an answer, but that is never as good as a study that has carefully considered important confounders and possible biases from the get-go. Even with good study design and appropriate statistical adjustment, you may be left with what is called residual confounding. Since it's impossible to measure confounding exactly, when you take away the effect of the confounder, you may have either over or undercompensated for it in the adjustment. This is particularly true for confounders that are hard to measure, like socioeconomic status. So what is the difference between bias and confounding? Confounding is something that is actually there in the real world. The initial association between the exposure and outcome may not prove significant, but the associations between all three factors remain. Bias, on the other hand, is not really there. There is no association. It just looks like it because of a systematically flawed way of selecting participants, gathering data, and/or analyzing results. In epidemiology, bias is divided up into two broad categories: selection bias and information bias. A selection bias is a systematic error in data introduced by how participants are chosen or choose to participate. A common example of this is the so-called healthy worker bias. When comparing a working population to the general population, the working population will always show better health indices. This is because in order to be a typical working person, you must not be ill or severely disabled. Entry into the worker group is restricted based on ability to work, causing a selection bias. This visual representation may help explain selection bias. On the right, you see the large pie chart that represents the true response to therapy in a population. When that pool of patients was sampled, however, there was a factor that caused more of the responders to be chosen as part of the study. For example, the study may have only looked at more severe cases of the disease that are more likely to respond to therapy. It is not a representative sample of the full population. The sampled response to therapy is biased because of the way people were included in the study. Confounding, conversely, may show you that some of your response is due to a different factor rather than changing the response rate. In this example, you can see that although the response is 50% for both examples, on the left, the measured response is 50%, and on the right, you can see that actually half of that response is from the confounding factor of exercise. Selection bias is sneaky and must be considered in almost every study type. Watch out for it in cohort or case-controlled studies that are done at single sites. Studies that have subgroup analyses may have selection bias in the creation of subgroups as well. It can even happen with randomized controlled trials. In general, you want to get a good understanding of how participants are found and recruited and selected or rejected from the study. For randomized controlled trials, the consort flow diagram that shows how many patients are in the target population, how many were assessed for eligibility, randomized, etc., can really help to give you an idea of the magnitude of selection bias in a given study. Be sure to look for this flowchart when reviewing RCTs. The other major category of bias is information bias. This catch-all term includes systematic errors in the data from its collection through analysis and interpretation. There are a myriad of different types of information biases. Recall bias is when knowing the outcome affects what the participant tells you about their exposure status. Surrogate bias is when the family of a deceased patient downplays the bad and exaggerates the good characteristic of their loved one. Measurement bias is another whole category of bias that deals with how precisely and accurately variables can be measured. Interviewer bias is when the way the interview is conducted changes the information given by the participant. Information bias can also take place when blinding is absent or broken. This is just a small sampling of the information biases. If you suspect a bias, try to find out the key features of direction, magnitude, and axis. If the bias is in the direction we call towards the null, or would decrease the chance of showing an effect, but an effect is still demonstrated, you can be pretty sure that there is at least that level of effect from your exposure. If, however, the bias is away from the null or increases the effect, it's impossible to say just how much of the effect is due to the bias and how much is due to the real effect. It's possible that once the bias is removed, the currently significant relationship might disappear. In other words, the direction and magnitude of bias might call into question or confirm the study findings. A key paper about bias is Bias in Analytic Research by Sackett, which goes through the main concepts of bias and has a nice appendix of many other biases as well. A newer paper in the Journal of Epidemiology and Community Health may also be of use to you as you go forward. Remember that some biases have several names. Others sound the same but are different, like survivor bias is not the same as surrogate bias. I have found in general that Wikipedia tends to have fairly basic and reasonably accurate explanation of biases, though you may want to corroborate with other sources for a more in-depth understanding. The Field Epidemiology Manual wiki on bias is also excellent. Remember, when looking at any study with an association, consider the explanations for that association. Bias and confounding must be ruled out before the possibility of causation can be entertained. In summary, remember to think about bias and confounding. Bias has two broad categories, selection and information bias. Both bias and confounding can be difficult to spot and can be in any step of the study. Remember, statistical adjustment cannot substitute for a good study design, so plan ahead. Material for this module was drawn from the 4th edition of Epidemiology by Gordis, as well as from the UBC School of Population and Public Health courses, Intro to Epidemiology and Clinical Epidemiology. Thank you for your time and attention.